All right, we're gonna get started. Appreciate you all joining. Sorry for the late. I'm having a little bit of technical issues on my side. For everybody who doesn't know me, I'm Dusty. I'm one of the founders of Koehler Health, and I have the pleasure of introducing Dr. John Koehler today, who is the founder of Doc One. I'm going to see if I can share my screen here. It's not letting me share.
I've got the outline anyway, so.
Okay, we're going to go. I'm going to see if I can figure out how to share in the meantime. But for those that don't know Dr. Koehler has lived and breathed Achmed for over 40 years now. He started an urgent care business. He grew that to 56 clinics, saw more than 10,000 Achmed company accounts during that time. And since then, he founded Doc One and has been helping urgent care clinics keep work-related injury care visits in their clinics. He moves fast, he talks fast, and so make sure, especially without any visual aids here, you have a notepad and ready to go. And we'll get started with the content. Go from there. Thanks, Dr. Koehler.
Okay. Thanks so much, Dusty. Appreciate that. So have your questions ready because I really want to help you with the questions. Anybody who wants to ask me a question later, throw me a case or something, I'm happy to help you out. My email would be jkoehlermd@occdocone. That's Doc1. The one is one.com. And I have, feel free to reach out. Anyway, so I've been practicing a long time. As Dusty said, you can see I earned my gray hair. At one time, we ended up with 56 clinics in 3 states. And so we grew from scratch. And so I definitely know a lot about this space. I have a great handle on how employers think, what makes them tick. And so I'm here to tell you that there's never been a bigger opportunity than now for occupational medicine services in an urgent care clinic. It can be done. We did it. And 45% of our revenue, which was about $45 million a year of occupational medicine related, that'd be workers' comp, physicals, pre-employments, regulatory exams, et cetera, made our mix. So $45 million grew from scratch. Nobody gave us anything. And so I know how to do this. And I really, really want to help you folks be successful. And I know the topic today is Achmed Magic, how to win market share fast. And I'm really serious about that topic. It sounds a little bit like hyperbole, but I'm here to tell you, I'd put $1,000 cash on this table right now, betting you that if you folks follow some of the things I'm going to say, especially as it relates to providers, you will be more successful than you are now. There is no shortcut, however. I can tell you exactly what you need to do, but you all have different types of challenges, contact situations, ownership, et cetera. But I'm going to tell you what you really, really need to do to win market share fast. So the Chinese character for crisis is interpreted as opportunity. So in the midst of this quote unquote workers' comp crisis in America today, which there is, because these companies have never been more depressed about the care they're getting in the communities in which they reside than now. They are safety directors' jobs depend on how workers' comp goes. And it's very depressing to them to see that, they go to urgent care and they just get triaged off to specialists. They go to specialists, they get taken off work, OSHA recordables, all that kind of stuff. And so that's a real big problem. But this crisis gives you the opportunity to succeed, opportunity to add incremental growth. You have a high fixed cost model. You've got real estate, taxes, staff, everything. So you got to have throughput. You've got to have it. And Achmed brings that to you. It mitigates seasonality issues with flu season, all that kind of thing, because injuries and physicals come in year round. Okay, that's it. What is the first priority? Without a doubt, unequivocally, it is and always will be, providers are the key issue. You can't simply say, okay, we have an ArcMed program, we can do drug tests, we can do physicals, we're open 7 days a week, et cetera, et cetera, et cetera. And the employers will look at you and say like, oh, that's great. But what about your providers? Because they know it's the providers, okay? You or somebody in your group might not know that, okay? Well, a doctor's a doctor, a PA, nurse practitioner, provider's a provider. Aren't they all the same? They have credentials, they have license, et cetera. No. Okay, that's true. but the providers are the key and they have to perform. There's a performance differential existing in providers today in America that is massive. Okay. And I'm here to tell you that you can advance your providers from average to rock stars in 3 months. Okay. The way you do that is you do the big four, which I'm going to give you those details here in a minute. But first, I want to talk about engagement, provider engagement. Okay. So what is provider engagement? Provider engagement is when they are pulling on the same rope you are pulling on. And you might be, you guys or any type of person within your program, but everybody's got to be pulling on the same rope together. So you need providers that are can-do-ski providers rather than no can-do-ski providers. You know what I'm saying? That, hey, we're going to start doing DOT physical. I don't think I can do that. Or we're going to do asbestos physical. I don't think I can do that. Oh, we're going to do work comp injury. Oh, I don't think I can do that. And that's toxic chemical poison. Okay. That's cancer on your clinic. Okay. Providers that say, no, I can't do that. Whereas providers that say, oh, I want to advance my skills. I want to do more. I want to keep my skills, advance my skills, etc. And those are the people we were recruiting because we were doing all that stuff. And so we had provider engagement because they wanted to be successful. So the idea is provider culture that wants the company, the group to be successful because a rising tide raises all boats. That's the proper mindset for an engaged provider. You don't have that. You need to really think about that. And this integrates very closely with your process of onboarding, recruiting and onboarding. And if you have the problem right now where someone, the C-suite says to you, well, we're just trying to keep clinics open, so don't bother me about that because our first priority is to keep clinics open and getting providers to be on duty to keep the clinic open. So that's a problem I can't solve. I can still tell you the secrets, but that's a problem that you'll have to solve. And I will say this, another thing about engagement. Engagement also includes, you have an agreement with your providers. You pay them a certain amount. They come to work. They do the job. Okay. And you want them to like you. You want them to come to work and you want to support them. You want to be nice to them. You want to keep all your promises with them, but you also want to provide them a reasonable lifestyle. So I'm going to give you a little bit of a sidebar secret here. If you have cluster of clinics, try to close on Sunday at some or all except one on Sunday. Why? Because that way the weekend work, which caused, I'll just give you an anecdote. I started many years ago, obviously. And as soon as I had enough clinics in an area, I would close on Sunday, except for one, tell all the companies and the answering machines and everything, go to here on Sunday, because lifestyle nowadays is huge. It's getting bigger. Why? A lot of the providers, God bless, PAs, nurse practitioners, the demographic has switched from, 50-year-old MDs, 40 and 50-year-old MDs, that are transitioning, out of family practice and ER into something like urgent care. That's changed. It's not like that now. It's young women that are PAs and nurse practitioners, and they get pregnant. Okay. They want to have a family. Well, if they're working every other weekend, that's a catastrophe for their lifestyle. Catastrophe. And we did a private equity deal and I lost control, or no longer in control, I should say. I gave it up by virtue of the private equity deal. And they immediately opened everything on Sunday, 8 to 8. And we started losing a number of absolute rock star PAs and nurse practitioners that left because of lifestyle. And we built such a really good provider organization with high engagement, and it caused a downstroke. And so just to give you another example, you've probably heard of Chick-fil-A, probably been in Chick-fil-A. They're not open on Sunday. That's a massive recruiting tool. If you ever looked at their staff is totally engaged, they're like a wonderful staff. So I think there's a connection there that mitigating Sunday. So that's a sidebar. If you have clusters of clinic, keep one open on Sunday, close the rest, help everybody's lifestyle. You don't make much money on Sunday, except maybe during flu season. Maybe you can, do a seasonal thing there on Sundays, but you got to help their lifestyle. Anyway, then training and support. Back in the COVID days, There was very weak training on procedures because they didn't have that many patients to deal with for procedures and such. So a lot of them even didn't have suture training. They certainly didn't have eye injury training. They didn't have fracture care training. And so you've got to step up and have them get the training and support. If you're going to ask them to do work comp injuries, they have to suture, they have to do eye injury care. They have to be able to diagnose and treat fractures. Minimal ones can be treated in-house, and more significant ones get referred. That's a whole different subject in terms of guideline and such, which I'll get to a little bit later. So you've got to come alongside them. You got to help them so that they can, in fact, do work. Because they'll say, I can't do workers' comp. I never did work comp before. Well, you've got to be able to help them do that. Okay, so now the big secret is the big four. Okay, so the big four. Now here's the magic. If your providers across the board consistently can perform by reducing unnecessary lost time, unnecessary OSHA recordables, providing common sense, intuitive work restrictions that fit the job the worker actually does, and call the companies on first comp phone calls. That means first comp injury, first visit injury, call the company contact person. They'll have a designated worker comp representative at the company. Could be HR, could be safety, could be who knows. But there will be somebody there that's your contact for workers' comp. It should be in your computer system when you make the account, set up the account, that you would call them up and give them a really short rendition of the case. Like, hey, Joe, I saw Bill today. He's got a lumbar strain. We're going to give him Tylenol and naproxen, back support, non-recordable. His x-ray's negative. He's going to come back to work with a 25-pound lifting restriction with proper lifting technique. Make sure he wears his back support. I'll see him back next Tuesday. It's that simple. I just did that in 20 seconds. So providers will say, well, I can't do that. I don't have time to make that phone call. Well, there you go. That's a roadblock to doing the big four. And, I didn't make up the big four out of thin air. I learned that because when I first started out in 1987, 88, I was going broke after the first, 9 to 12 months because I didn't know anything about anything except really good clinical medicine from my ER training. But I had a friend when I went back to Penn State to visit some friends. One of them starting an urgent care clinic because I went to Penn State. He said, hey, I started an urgent care clinic. Did you really? Hey, so did I. Wow, tell me, let's talk, He goes, yeah, you guys doing DOT physicals? I go, what's DOT? He goes, Department of Transportation. I go, oh, okay. So that's where I was at, right? So I learned from him. I came back. I started getting trucking companies for their DOT physicals, and then the workers' comp started to roll in, thinking, whoa, they get injuries. And the amount of money on a visit, because you get the E&M code, the visit, plus the x-ray, plus the recheck visits, I knew that was, wow, that's kind of lucrative. So I started really getting into doing workers' comp. And that's how I first started out and realized I could drive revenue with the telephone. And I started recruiting first trucking companies and literally everybody else. And I hired an occ-med nurse in town who knew a lot of employers. And so we kind of figured it out and we developed a hybrid model early on. And so our providers were engaged because I was realizing that the only way we could survive is with occupational medicine with that traffic, because like I said, I didn't know what I was doing. Sorry, but it didn't. The location. So there was this first clinic that we had was put up by a spec builder out of Decatur, Illinois. And he put this clinic in Rockford, Illinois in a good demographic location for urgent care, but horrific visibility. It was a 5,000 car a day. And if you know anything about that, you should be at least 20,000 cars a day for a clinic nowadays. But this was it was basically an off-road. Okay. And so, but that impediment that greatly reduced our ability to get urgent care patients turned out to be the thing that drove me by a matter of survival into occupational medicine. So serendipity. And so we started growing it and we're able to make a go of it because of that. Anyway, long story short, I went out to meet with companies. I'm selling it. I said to them, what matters to you? And their eyes get big, like, it's the first doctor that's ever come to our facility and you're asking us what we want. It's like, holy cow, they think they died and went to heaven. Anyway, they were happy to tell me, and almost verbatim, it's the big four. Okay, they'd say, well, doctors take people off work all the time for little things. And they'd say, and like recordables, they could care less. They just write prescriptions willy-nilly for everything. Why does everybody need a prescription on the first visit? They just have a sprain, strain, or contusion, etc. Then they'd say, like, we have no idea what's going on. Nobody ever calls us. If we do call, we get a nurse. And the nurse says the doctor's busy, can't talk to anybody, never know anything. So I learned, I wrote it down, and it became genetic within our company that we do the big four. Okay. And then obviously I created OcDoc One. It has the big four built into the guidelines. There's 400 guidelines for injury care. And if you go through the guideline, do what it says, you will do the big four properly, and you will gain market share, and you will have providers that are viewed by the employers as rock stars. Now, your providers may not think they're rock stars because there's 3 months. How do I get to be a rock star in 3 months? To the employer, you will be a rock star. Maybe to yourself, you're not, but to the employers, you are. And notice the big four that I listed. This is not putting a shoulder back in. This is not sewing a tendon. These are administrative issues that are driven by your pen. Okay. So lost time. Don't take people off work unnecessarily. And I might have taken 5 people a year off work, maybe. And probably those 5 all were going to the OR for their Colles fracture, for their, whatever serious injury they had, that they're going to the OR. So they're off work. Okay. Obviously. So maybe 5 a year I was taking off work because you can give light duty. Okay. You can put a splint on their arm and they can still go back and use their left arm. If the company decides they want to send them home, they can send them home, but at least you didn't take them off work. So that's the first thing. Off work only if absolutely clinically necessary. I didn't say indicated. I said necessary. Okay, I guess indicated necessary kind of close, but it's got to be a necessary thing to be off work. I might take someone off work who's got a cellulitis with lymphangitis, bad infection. They got to be home to elevate, warm compresses, those kind of things. So there are indications. I'm not saying there never is, but few and far between. The second one is OSHA recordables. And so we have this syndrome out there in the medical care land that if an employer is asking you to do something administratively that will help them in their paperwork with the government, it must be tainted. It's kind of a conflict of interest. This is strange. Why do we do anything that the employer wants? They're just trying to get their own way, blah, blah, blah. Well, to a degree, I guess technically they are asking you to do something different to help them with their paperwork. But I believe it's a reasonable request that for routine strains, sprains, contusions, notice strains, sprains, these are not life-threatening. Okay, these are not limb-threatening. They would like us not to provide a prescription drug on the first 2 visits, maybe for the whole case, because patients get better after 2 visits, right? A lot of improvement. Things change rapidly. So Tylenol plus an NSAID, which would be Aleve or ibuprofen 200, Aleve 220, ibuprofen 200, and the non-recordable dosage. Tylenol is never recordable because Tylenol is OTC. There's no milligram amount that makes it recordable. So if you get both of those together, I've searched the literature and found that those 2 together gives adequate, clinically significant anti-inflammatory analgesic coverage for them as good as Tylenol 3, which is a narcotic. Okay. So I've done that. We were dispensing, 10,000 plus prescriptions of that. We'd give everybody 2 bottles for a routine sprains, contusion. They get 2 bottles of prepacked pharma. It's already prepackaged for them. They walk out with it. They feel good. They get their DME, they get their paperwork, and it's good. So why is that bad? Who needs cyclobenzaprine and Mobic on the first visit for a routine sprain, strain? They don't. Who needs a prescription drug for a routine sprain, strain in the first 2 visits? Very rarely. I'm not going to say never, never say never, never say always, but if you want to get to rock star status, this is what it is. Sorry, this is what it is. I have experience over 40 years, 10,000 clients. I know how they think. I know what they want. Okay, thirdly, intuitive common sense work restrictions. So a lot of EHRs have these boxes that you can check for work restrictions, like no running, jumping, or ladder climbing. Wait a minute. Why would you check that box if nobody runs, jumps, or ladder climbs at their factory? Or even if that person's job doesn't involve running, jumping, and ladder climbing. It drives them crazy when you give them a restriction that makes no sense to their job, because then they know right away, your provider did not even engage with our employee about what job they actually do. So you need to know the mechanics of the job they actually do and give the restrictions irrelevant. For example, if you are an office worker with an injury, a work comp injury, if you can get hurt in the office, so they have a work comp injury, they're an office worker, coming back to work is very likely to be full duty for their injury. Why? Because their job is sit down, desk job anyway. So why would you give them a restriction? Give them full duty, even though you would normally say, okay, they get a 25-pound lifting restriction because they strained their back because they slipped on some condensation on the floor coming in, or it got wet on the floor. They slipped on the way in. They got a work comp injury. It was a hazard at work. They have a lumbar strain, but their job is a sit down desk job. They would be full duty. Okay. In the factory, you would still give them the restrictions that make sense for the job they do, that matches up to the restrictions that their injury requires to enable them to get relative rest on the structure that's injured so it can improve. We also give them DME to give it relative rest for like a lumbar support, wrist support, tennis elbow strap, whatever it might be, to help give them relative rest for the body structure that's injured. Okay, that's the third of the big three. Fourth, call the company, do the first phone call. This will not kill you. Okay, you can have a Bluetooth in your ear. You can make the phone call where you're typing into the EHR if you want, and it only takes 15 seconds. If they don't answer the phone, you simply leave the message on their answering machine. Okay, what I have just told you is magic. What I've told you is a trade secret. What I've told you is the absolute singular number one agenda for building a work comp program. Okay, this does not require a kind of a hospital system brand name. This does not require 8 to 8, 7 days a week. This does not require, the perfect location. Okay. They just want what these big four. Please just give me the big four. I don't care. I'll go to an office building somewhere. I don't care. We'll go 30 miles to get to you if you do this. I was pulling from 150 miles. Granted, not many, but I had a nuclear plant that would drive 150 miles to reach us because of recordables. Okay. And you can say, well, there's not many employers where we live. Oh, yes, there is. Don't give me that. There's employers in the woodwork. I don't care where your clinic is. You can bill 20% of your revenue in work comp med. I can guarantee you that. We were 45%. And work comp, by the way, enables you to get locations that might not be perfect urgent care locations, but they're really good hybrid locations for OCMed and urgent care. And that helped us get from our 56 clinics. We had a bunch that might not have been the greatest, a number one urgent care site, but we were seeing 120 patients a day. Combining, we were doing like 60 OCMed patients, 60 urgent care patients. And that's very profitable when you get to that. When you can get to 60 patients a day, it's very profitable. And we had inner city Chicago or downtown Chicago. We had Koehler counties. We had city residential. We had rural small towns. We had it all. And we did workers' comp at every one of them, and they'll drive to you. And I'm telling you, you can do this. Okay. So let's keep moving here.
Hey, I'm gonna pause you for a second since we don't got it on screen, and
it came up. You got my first slides up.
Can you repeat for the group though slowly the big four, like what are the actual big four are at a summary level?
Okay. Big four. Number one, unnecessary lost time. That means taking people off work. Number two, unnecessary OSHA recordables. 90% of those are prescription meds that patient didn't need, because if it's a prescription, not an OTC level, it's recordable. 90% of unnecessary OSHA recordables are prescription drugs the patient really did not need clinically. Number four, or check that. Number three, intuitive, common sense work restrictions. Number four, first comp phone call.
Great. And that came through a question. So keep asking questions in the Q&A. We'll take Q&A at the end. So keep doing that. Sorry, we didn't get to do a proper intro with our tech issues, but all right. I'll go to the next screen and keep it going.
Okay, leadership. This is secondary. This is not the big kahuna, which is providers, but it's good to have C-suite buy-in. That means your CEO, whoever's in charge from a business standpoint, needs to recognize the importance of occupational medicine to drive revenue and drive bottom line profits, profitability. You already have all the infrastructure in place, site selection, building, tech, staff, x-ray machine, rent, all that stuff. So why not add in incremental volume to help build revenue and profitability? So C-suite needs to support this because you have to buy certain things to support it. You might want to do certain bonus issues related to Ahmed, which is not germane to this talk. We can do a bonus talk at some point. We can also do a how to properly monetize occupational medicine in a future talk here with Dusty. He can address his side of things from co-work. I can discuss my things on how to monetize properly, because obviously C-suite wants, how do we monetize this? Does it make money? Okay. Then the chief medical officer, who is a provider, okay, this would be your most important singular provider, and therefore your most important singular human being in your practice to help this happen, to build your Ahmed successfully, to have the Ahmed magic going and gain market share fast. So your CMO needs to be fully engaged. Your CMO might not understand Ahmed. Your CMO might not even have background in Ahmed or workers' comp care. If not, that's a serious problem, a serious issue. I am happy to engage with any of you. If you want to reach out to me by email, we can do a phone call to talk about your particular individual situation with your chief medical officer. There might be chief medical officers on this phone call right now. That's great. But the CMO is the lead physician, lead provider, and must be engaged, pulling on the same rope, excited about Ahmed workers' comp, willing to roll up their sleeves and train the providers on how to do workers' comp treatment, eye injuries, laceration repair, do pig's feet workshops, sewing up pig's feet, taking corneal foreign bodies, such as practicing on hard-boiled eggs to remove foreign bodies off of hard-boiled, because that's easy with the Opti Spud. They need to learn that. You've got to take foreign bodies off the cornea. That should not be referred to ophthalmology, et cetera, et cetera. So they need to be positive about it. If they're like Eeyore, no Kanduski, I don't really want to do this, then you're sunk. I mean, quasi sunk, unless you solve the problem and get engagement. So I can help you in unique situations. You can ask a question during the Q&A on that. Next is operations. The place has to be functioning properly. You have to have the drug test supplies. You have to have the chain of custodies. You have to have the things that you need, the equipment to do worker comp injuries, laceration repair kits, IND kits, eye kits, all the supplies, magnification for the head mounted magnification or slit lamps in your clinic. So operations is important. Okay, next slide. Sales. I want to talk about sales, how to gain market share fast. So your salespeople, now this sales will not work unless you have the big four I already mentioned above with providers. So again, the big kahuna are providers. But once you have 3 months under your belt with the providers doing really well on the big four, and perhaps even using Ocdoc One, which keeps them all in line, you standardized care around 400 different treatment regimens, then your sales gets easy. Okay, so your sales staff must have an elevator speech. They've got 20 to 30 seconds on the phone with the person they're calling at. And this is the person at the employer who, quote unquote, handles work comp. This could be multiple, it could be a secretary, HR director, HR assistant, safety director, plant supervisor, whatever it could be. But you have to have a 20 to 30 second little elevator speech. If any of you are using Ocdoc One, just go to Quick Check, type in elevator, hit search, hope it'll come. There's my elevator speech, copy it. Take it, use it. It's right there. It's magical. I used it, built, obviously, $45 million a year revenue practice with that elevator speech, because I mentioned the big four in the elevator speech. Okay. I'll never forget. I was in Fort Wayne, Indiana. There's a big company that made axles for a large automotive company. I wanted to get the account. I kept calling during, 9 to 3 business hours, couldn't get them on the phone. So I used a technique where I would call outside of hours because they think it's a emergency call. So I called it like 4:30 in the afternoon. He answered the phone. I gave him an elevator speech. He said, okay, all right. Well, 2 of those things matter to me, so I'll take the meeting. We got the account. Was a good account for him. So those big four I just mentioned are your sales tool. Okay. Because if you do not mention the big four, why should they care about you? You're no different than everybody else. Like you call up and say, hey, we're Acme Urgent Care. We're located at Maine and Maine, and we're only 3 miles from where you are. And we do occupational medicine. We're open 8 to 8, 7 days a week. And they go, hey, that's great. Good to hear. Hey, we already have somebody. We're happy with them. Well, thanks much. I'll keep you in mind. Goodbye. And you hang up. And you just got zinged out of it. When if you would have said the big four, they would have said something like, well, that's interesting. Yeah, we're interested. Let's have a talk. And then you could do a Zoom call, or you could go there and obviously preferably meet with them, but you could do a Zoom call with them. But then in your meeting, you're obviously hitting the big four, and they're going to want to know about the big four. They're going to want to make sure, well, what makes you so sure the providers are actually doing it? Like, how do we know? Now, if you're on OcDoc One, you can say we have guidelines, OcDoc One, we use it. It's endorsed by our medical leadership, and everybody's on the same page. So we have consistency of care around the big four issues. And you can name them, obviously. And that would get their attention. If you're on a Zoom call or in a meeting, you can bring up OcDoc One on your iPad or your computer and show it to them. And if you demo lumbar strain and you show them validation steps in there, plus the issues of enforced employers, which are the big four, they will think they died and went to heaven. They will ask you, how soon can we sign up? It's that crazy effective. So your sales staff needs to be engaged on having the right elevator speech for the big four in it. They need motivated. You need to have a bonus program so that the more revenue they bring in, the more money they make on a bonus program. And the great differentiation, if you call up and just describe your program without differentiation between everyone else in town, you won't get anywhere. And the differentiation is the big four. Trade secret, I'm promising you what I just said is an absolute trade secret, because your competition not only is not saying anything about the big four, but they're not doing the big four. Therefore, companies will scramble to come to you. The word of mouth will spread. It's magical. Okay. And so that is the sales side of the presentation today. And I'm also happy to engage with your sales staff. And I have a sales presentation within OcDoc One that you can simply type in on Quick Check. OcMed Sales, up will come the presentation. It's like 45 minutes only, strictly on sales. That too is extremely beneficial. If anybody, do you want a demo on OcDoc One itself, I'm happy to do that too. You can reach out to me at the same email address. With that, let's open up. Hopefully we have questions. Anything goes. Happy to challenge me. No problem. Happy
Yeah,
to
let's
any questions.
with Dr. Koehler. We do have some questions. Again, like since I didn't do a good intro, but on the screen here, both our emails here. If you need to reach either one of us, Dr. Koehler's website, mentioned a few times, ocdoc1.com. You can find those resources or sign up, and then coworkhealth.io for our service, which is a platform to help manage your relationships through a portal, billing, all that good stuff. So first question though, let's dive right into it. We got, what do you think about integrating ODG in the EMR, where it can provide a customized care plan based off the patient's underlying illness, age, BMI, etc.? Is it worth the investment?
Okay, great question. I've looked at ODG guidelines. Unfortunately, those are late in the game. Okay. Disability guidelines. All right. Probably like 2 to 3% of ultimate injuries involve any disability at all. So ODG is late in the game. It's benchmarking for disabled injured workers. Like, when should they come back after their tib fib fracture or something like that? So it's applicable, but way late in the game. It's more for insurance adjusters than it is for case managers and insurance adjusters than it is for ground and pound clinics. So OcDoc One is the ground and pound solution for how do you treat the patient right now on visit 1, visit 2, visit 3, visit 4, visit 5, etc. And ODG doesn't provide that. So, yeah. And I can, if you want a demo of OcDoc One, I can show you what it does and how it can work on a daily basis for your provider. So it's, I'm guess I'm tooting my own horn, but ODG comes up a lot, but it's disability guidelines. That's not what work comp is. We're treating acute injuries.
Great. Can you repeat the prescription, non-recordable that you dispense? Tylenol plus something else.
Yeah. Okay. So NSAID, NSAID stands for non-steroidal anti-inflammatory medication, which includes many, many medications. But the non-recordable ones are Tylenol. Tylenol's not an NSAID, but Tylenol is acetaminophen. That's the one non-recordable at any dose. Then combined with an NSAID, which would be ibuprofen 200, which is Advil, or naproxen 220, which is Aleve. Okay, so you give Tylenol 500 milligrams 4 times a day, plus ibuprofen 200 milligrams 4 times a day, non-recordable, or Aleve 1 to 2, 3 times a day, non-recordable. Now, like we gave them the bottle, we told them what to take. If they take more than that, that's still not germane to us. We don't govern how many pills they pull out of the bottle and take. So they could, quote unquote, take a prescription level of Advil or Aleve, but still our dosage that we put in our chart, we're not telling them to take more than that. We're not, because that's cheating and not being forthright. And we always tell the truth. It's whole truth and nothing but the truth. But sometimes they take more. It's not our issue. But and the OSHA log, by the way, is not our responsibility. It's 100% the employer's responsibility to fill out. There's no liability related to this at all. But anyway, that's the dose and the drugs. And it's in OcDoc 1, it's listed the exact dose and the non-recordable dosage is right in OcDoc 1 and all the guidelines.
Right. You mentioned where to find the outline for your elevator speech. Someone asked me where they can find that.
Yeah, go to Quick Check in OcDoc 1, type in elevator in Quick Check, hit search, up it comes. And this what Dusty's showing right now is only our internet facing page. This is not the website itself. This is how you can order up a demo with me. Yeah. But you'd log in like that on the, if you want to, I'll give you temporary access to the website to look at it. If you get a hold of me, we do a demo, I'll give you temporary access to get into OcDoc 1 and look at stuff prior to subscribing. So you don't have any risk involved financially.
Right. Here's a can of worms for you. How do you manage work comp billing delays and network reductions?
That's 2 questions. Okay. So, work comp billing delays. Is that delay in payment? I guess I'm assuming delays in paying you.
Yeah, I would think so.
Okay. That's a Dusty question, actually. Dusty, you should answer that because you're better at that than me.
We are more focused on the EPS employer paid side for sure. So work comp billing delays, it can be tough. I mean, so much of that is process, procedure, clearinghouse, and how those carriers are getting your claims in the documents, right? So do you have a good process management, good people managing, making sure the claim goes out with the supporting documentation right away is the first time. You have a claim number, you have all that good stuff. Nothing that's rocket science that I'm talking to, but yeah, work comp billing delays versus employer billing delays where we could chime in a little bit more, but.
Yeah, I know, national class. I mean, really spectacular class individuals that do consulting in this space, specifically on billing issues, will say that the vast majority of delayed payments on claims is the clinic's mistakes in how they code it. They're not coding it right. So these insurance companies have algorithms in their system. They'll spit that bill out instantly. It has to be really good. If it's a quote unquote clean bill, they'll pay it. So if you want to reach out to me, I can connect you with consultants that can, consult with you on a short-term basis, very economical. And these people have really turned some groups around and saved them hundreds of thousands of dollars by giving them, quote unquote, trade secrets on how to make the bills, fill out the bills properly. So you can reach out to me on the reductions. Yeah, you have to be in network. And if you're in network with Liberty Mutual, Gallagher Bassett, all that, they're going to take off 10 to 15%. That's you're stuck with that. But that also speaks to proper monetization, which we can do a talk on that everybody moans and groans about the bad reimbursement, which is true and valid to moan and groan about it. But at the same time, take some of the energy of moaning and groaning and properly monetize, like do the procedures and do the DME and do the x-rays. That's a lot of money. So a work comp case, you might have a delta, they might reduce you 10 to 15% on your E&M code. But if you get a $75 x-ray, that's a lot of money. You do $100 back, you make $100 on every back support. I mean, that is huge money. And clinics aren't doing back supports for lumbar strain, most common work comp injury. $100 net, $100 profit. I can tell you how to do that. We'll do another talk on monetization, but yeah. Next question.
Yeah, I'll tell you Lisa, that was Lisa's question. She had a follow-up one that was, looks like they're currently trying to get out of network discounts and carriers want to drop them. And so I think that was part of the context.
Out of network carriers.
Yeah, there might be a typo, so I'm trying to read between the lines here, but it says currently trying to out of network discounts and carriers want to drop me. But yeah, if that doesn't.
You can go out of network, but the bigger employers will tell you we're not permitted to go out of network to the provider. So I will say this, that if you do the big four, you're in a vastly better position. There will be companies with the desperation level so high, they will say, we don't care if you're out of network. You're so good. We're going to use you and make sure, and we'll tell the insurance carrier to pay the bills. I've had that happen. I really have had that happen. They will say, we don't, because I'll tell them, I'll say, look, if you want our services, we've chosen not to sign a discount contract with that particular network, but we'll see your patients gladly, but you just have to pay our bills. Go, okay, no problem. You'll pay your bills. You're that good. We'll pay your bills. But you got to do the big four. I'm telling you, you won't get their attention without the big four.
All right. I don't think we want to go too deep on this one, because this might be a future call as well. But Frank is asking if you could elaborate on the bonus structure and pay scale for a marketer.
Okay. High level view. Okay. So you have to, it's important to incentivize them. Sales, you got to be driven. You got to have the carrot. Okay. So optimally, you could hire, like the range is like, say, somewhere between 35,000 and 80,000 a year salary. And why the huge range? Because a rookie coming in doesn't know anything. They don't even know the vernacular of you can't make a phone call for work comp and do the elevator speech without knowing what OSHA freaking is. Okay. So that's somebody green coming in 35,000. 80,000 was somebody who's got a huge book of business with your competitor who comes over to you, and they might be able to bring clients with them. So they might be worth, and they know all the vernacular. They've been doing it for 20 years. They might be worth 80,000. Okay. Now you want to have incrementally at least $40,000 upside on a bonus program, at least minimum 20. You won't get their 10 with 20,000. So a $35,000 employee with a 20,000 bonus opportunity is a big delta for them. Okay. Highly motivated, whatever it is you need to motivate them. So I never had problems with, I had a salesperson was so good. She evolved from sales into literally running the EPS program of our clinic completely. And she ended up making 130,000 a year. Okay. She was a rock star, but she started in sales. And so, but you want to have a bonus structure, and you have to pay, no less frequently than quarterly. If you have a bonus program that pays every 6 months, that's junk. Throw it away. Monthly is the best, obviously. That you want to give that carrot frequently, once a month, no more than quarterly. You got to have it quarterly or less. And then you pay on the business that they bring in, and you pay them for the first 3 years on a graduated scale. So you could give them, say, starting out 8% in the first year, 6% on the second year, 4% on the third year. Then after 3 years, they don't get a bonus on it anymore, because you can't have them, you want to keep them hungry. Okay. And you can do the math. You can figure out what you're, and you don't have liability on these bonuses, because you're not paying unless you collect the money, and it's collected funds, and you must exclude flu shots. Okay. So flu shots, revenue, no. Okay, it's got to be worker comp and EPS, but exclude flu shots. You have to make an exclusion for that. You need a non-compete too with it, and you need to monitor them in the first 6 months to make sure they're actually having meetings. I've seen a lot where they'll go to Starbucks and do Facebook and social media until after 6 months you figure out that their reports on their meetings were fraudulent, and then you fired them. But it costs you 6 months of opportunity time. So you have to audit them. That means you have to call the company that they said they met with to follow up and say, hey, how did it go? Janie or Bill, how did it go with them? They go, I have no idea who you are and who you're talking about. We never had a meeting with Janie or Bill. So, okay, next question.
We're at time that we have scheduled, but Dr. Koehler, do you have a few more minutes to go through a few more?
Yeah.
Okay.
Yeah, I can't. Anybody can jump off if they want. If they got a deadline.
Yep. And our emails again are on screen. So email either one or both of us if you don't get your question answered today. But next one is, we are running into several companies transitioning from our MRO services to eScreen. These decisions are made on the corporate level. We currently cannot process electronic COCs. We have competitors that can and have taken our business. What's your take on this?
Okay, first take is that losing that business is not a huge loss. eScreen we fired eScreen. Most of the folks I've worked with, they can't work with eScreen because they fill up your office with $15 drug tests. Your cost basis is 10. You make $5. It's not even worth checking them in. It's not worth them sitting in a seat in your waiting room, making it look like you're jammed. So the patients go to the glass door and walk away. Good paying urgent care patients leave because it's like, I'm not waiting through that. And they didn't know that 6 drug screens that didn't involve a provider. I don't like eScreen, okay, at all. Okay, so that's one problem. I'd almost say good riddance to eScreen. So electronic, I guess if they have, I wouldn't worry about it. So the second thing I'd say is, if you're doing the big 4, let the eScreens go and they'll bring you your work comp and your respirator physicals and pre-employments and asbestos exams and all that kind of stuff. So you get the good. We literally had department stores being sent in by eScreen. They've got no injuries at the department store. They didn't even send us to them. They were sent somewhere else. And they were just filling up our waiting room with drug tests. So that's my answer, that you got to do the big 4, keep the workers' comp, and that's where your money is. Sorry, that might not be a very good answer, but that's my answer. That's what we did actually for our 56 clinics.
All right, next one. Aside from the elevator speech, pitch, and sales video, what other trainings currently in Octac One would you recommend as a priority to watch for an administrative person who assists in administrative case management, sales, contracting, etc.?
Okay. Watch the Fundamentals of Ocmed video series. There's 12 videos. Watch those in their entirety. Then go type in Ocmed, OCCMED, two words, in Quick Check, click search. Up will come my Ocmed sales training program. Watch that. And you will know incredible information if you just do that. And plus the elevator speech, of course, watch that or read that over. Yeah. You can frame shift from low knowledge to high knowledge in 1 hour.
All right. If you're dispensing ibuprofen, Tylenol, or naproxen, or the counter strength at the clinic, do you charge either employer or workers' comp insurance carrier, or just give them out?
Great question. Should have said that before. I should have answered that in my talk. We billed it under workers' comp and we got paid. We'd pay like $2 for the bottle. We charge 15 or 20 and we got paid. Not everybody, but you don't need to get paid by everybody. If you have this absolute idea that everyone's got, so what if you give away a few pills, a few $2 bottles for free for the few that don't pay? But the convenience, the one-stop shop model, oh my goodness. Yeah, it's worth it. And so you can charge $15 and they're happy to pay it because they don't have to go to a pharmacy. And you didn't give them a prescription that's OSHA recorded.
All right, we'll do one more here and then we'll let everybody go. But again, feel free to email us your questions. Some of the employers um, want us to avoid sutures when appropriate, but use steri strips. Maps this all to avoid recordable. They're fine sending employees every day or every other day, any number of visit limits from the insurance payers for more visits than average. That's a question. Any number of visit limits from the insurance payers for more visits than average. That makes sense?
Okay.
That's done
All
with
right. So I'm going to answer the second one first. There's no such thing as a limit of visits. I would say the average, our average was like 3.3 visits per work comp case. So, lumbar strains might average 5, or, 3.5 to 5. Sutures might be 2 visits. So it varies. There's no limit. No one ever said to us, we'd hit our limit of 8 visits at your clinic. That never happened. They might have done that directly with the employer or the patient to say, we're going to have you see a specialist, and they take them away. That probably happens some. There's no real anything written or in stone about that. But obviously, the less number of visits, the better. But I always advocate, and it's in my guidelines, that rechecks in 4 days, 4 to 7 days. I like 4, 5, or 6 days. Things change quite quickly. The companies don't mind rechecks early and often because the patient's getting better. You're advancing their duty. The other part of that was suturing with steri strips and such, or in lieu of sutures. So I've always trained my providers that if it needs sutures, we're putting sutures in, period, full stop. We're not going I do not like glue. I do not like steri strips. For lacerations that need sutures, I'm suturing it. Why? Because the others come apart, okay? And if they really care that much about recordables, which obviously that client really does, because that's a little bit over the top, okay? I've had that question many times, okay? But the answer is, ladies and gentlemen, there was subcutaneous fat visualized in the wound. It's beyond the dermal depth. It really needs suturing to properly close this and keep it shut, avoid opening and avoid infection. So we're going to irrigate it out very well. We're going to have to suture it. Yes, it is recordable. We're very sorry about that, but that's what the patient really needs. And they'll usually say, okay. If it's non-dermal depth, if it doesn't go through the dermis, you can glue it or steri strip it. Of the two, I guess I really don't care. But the OSHA says if glue or steri strips are used in lieu of sutures, it's recordable. And that's obviously a dumb nuance, but it's true. It's right in there. So you would have to put in there something like dermal depth doesn't require sutures, but we're going to use steri strips and glue as a dressing, or steri strips and or glue as a dressing. Then it's non-recordable. So you can do it. And I did it on some that were only dermal depth. But if it's below the dermis, you subcutaneous fat underneath, you got to suture it, because these workers, they break stuff. I mean, sutures come apart as it is. Okay. So you got to do it right. It's the ethical thing to do. Sorry, but that's how it is. And they should love you to death already, because you're giving OTCs for the first 2 visits for routine sprains, strains, and contusions. You're already saving them 90% of the unnecessary recordables already with you not giving prescription drugs. That's the big kahuna. It's not the steri strips that save that many injuries. I'll throw this one in for free. Avoid antibiotics for routine eye injuries. You don't need it. You're rechecking all eye injuries the next day. Anyway, I've never seen a corneal infection in 40 years and hundreds of thousands of eye injury patients. Ever did we have an infection of the cornea for corneal foreign body, corneal rustring, corneal abrasion. It doesn't happen. The thing that causes them is contact lenses, and that's not workers' comp.
Okay. We're going to call it for today. We will be doing another one and another similar type topic with Dr. Koehler in the nearest future. Appreciate the engagement today and you all sticking on through tech issues. Again, our emails are on screen if you want to reach out to us in between now and the next one. Otherwise, again, thank you for joining us. And Dr. Koehler, thank you as always.
My pleasure. Take care, everybody.